Well, again, good afternoon, everyone, and welcome to this RAAP PDAB webinar. Our specific topic today will be on Virginia to provide all of you with an update on where we are in terms of the status in the state, the particulars about the current bill that's being reviewed by the governor, and then we will be looking into three specific areas, looking at the mechanics and why this new bill doesn't work, then looking at kind of jurisdictional issues and authorities, and then finally the patient journey and how this bill could impact access in the state of Virginia. So we have a terrific group of panelists today. Three of my colleagues who I am very excited to spend an hour this afternoon with. And we will begin by allowing them to introduce themselves. And we'll start with Derek Flowers, and then I will jump in and give you a quick update about Virginia before we begin our discussion. Derek?
Great. Well, thanks, Mike. Great to be with you this afternoon, and thanks to everybody watching. I'm Derek Flowers with the Value of Care Coalition. We are an organization of healthcare provider, patient, and caregiver organizations that takes part in policy discussions around cost, value, access, and affordability, largely at the state level, all around the country. And so what we're seeing in Virginia now and in other states is of great importance to us and our members, and I'm glad to be here today to talk a little bit about it.
Thanks, Derek. Bill?
I am Bill Sorrell. I am a professor of practice at the University of Maryland Law School and a recovering pharmaceutical lawyer after many years of practice, now quote unquote retired. And in my quote unquote retirement, one of my great privileges is to be a select volunteer counsel with RAAP.
Well, thank you, Bill. And we look forward to this discussion. Bridget?
Hi, I'm Bridget Danderosa-Rett, and I'm a patient in Colorado. I've been through the UPL and the affordability reviews for Enbrel, Stelara, and Cosentyx. And I run an organization called Advocates for Compassionate Therapy now and the Colorado Rare Disease Coalition.
Well, thank you, Bridget. We're excited for this discussion today. And first off, I'd like to say thank you to everyone who has signed onto letters, who have written their own letters, emailed, had meetings, posted on social media, and basically all the communications around the Virginia PDAB issue this year, including the last minute substitution bill and then final passage in the General Assembly. We've heard that the governor's office is getting a lot of information from all of you, and that it's making a tremendous difference in terms of their understanding of the bill. And we hope that that makes a difference. So I just wanted to begin our discussion by thanking all of you for participating, getting involved, and making sure that your voice has been heard. The governor has until April 13th to act. And then the General Assembly will come back on the 22nd for a one-day reconvene session to answer any actions that she may take on the bill. Right now, we're hopeful that we'll see some amendments, but her staff continues to be very closely guarded with the specifics. There was a new FIS released on March 23rd. And for all of you on the call, a FIS is kind of like a fiscal note. And that amount was not seen by members before they voted on final passage of the bill. And I think it took many people by surprise in terms of the overall amount. And we'll talk about that in just a moment. But I want to just close by saying there's still time to make your voice heard with the governor's office and write a letter of concern. Please continue to do so, to contact the governor either by phone, email, or mail. And if you need contact information, we can share that appropriate contact with you if you need that. So with that, I'd like to tee up our discussion and turn some time over to our panelists, because we've got a lot to talk about in Virginia. And then we will close our discussion by talking about the impact Virginia could make on PDAB efforts in Illinois, Louisiana, and potentially Rhode Island. So with that, I'd like to turn just a moment over to Derek Flowers. Derek's going to talk to us a little bit about the mechanics of this bill. Derek, a lot of people were told as this bill came to the floor, that it was purely an advisory board now, that it didn't deal with price control issues or upper payment limits. Could you explain to us a little bit about what's actually in the bill and why that may not be 100% accurate?
Yeah, well, 100% is the key word there. I think that's maybe 50% accurate or so, right? Um, when this bill got started, it was a bill like we might have seen in a lot of other states, right? It created a prescription drug affordability board. It was going to look at the costs of certain drugs, do some sort of cost review or analysis, determine whether it's affordable or not, and then have the ability to set an upper payment limit. It was instructed to use Medicare's MFP where applicable, but for the most part, the board was going to operate a lot like we see in other states. And it was clear, Mike, there was a lot of pushback to that. Groups all on this call, raised concerns about what we've seen in other states and the challenges that the existing PDABs are seeing. I think the governor, heard us, and certainly some in the legislature did too. And there was work to change the bill. Unfortunately, the change we got wasn't the change that we wanted. There is still a board or a commission, I forget how it's termed now, but a group of people who are tasked to do studies related to the costs of medicine in Virginia. But they don't have the authority to set an upper payment limit, as you said. The other part of the bill, however, creates upper payment limits automatically. No longer is it the board's responsibility to consider whether one is needed, figure out a price, and implement it. Now, once a price is set at the Medicare level, Medicare's maximum fair price, that is automatically going to become the upper payment limit in Virginia. And so that's what's got people concerned, right? It's an upper payment limit just arrived at in a different way. And I think that when the bill changed so fast, some of that nuance might have been lost on some of the members in the legislature.
Thanks, Derek. Bill, as we look at that and look now at this new mechanism, which is basically to take a number that's generated by the federal government through a negotiation process under Medicare Part D, and then apply that as a UPL. There's certain concerns that kind of automatically pop up. Could you talk to us a little bit about both concerns with the number as well as how it would apply in Virginia and why that could be problematic?
Well, we could go on forever probably with that. There's quite a few things to be concerned about there. So one issue is that, of course, we don't really know at the federal level what the impact of MFP is. It's just being implemented. We have less than a quarter's worth of data. That data has not been analyzed. There is some possibility that just operating at the federal level, that there already may be changes in prescription and pharmacy practices to at least some degree based upon its application just in a Medicare context. If we layer on that now the possibility that one or more states could effectively adopt that price at the same time, then even the predictions that were made with respect to the use of the price at the federal level might not be very good predictions any longer, because we're introducing that pricing metric more broadly and in a way that was never analyzed when the metric was considered for federal purposes. So that's a pretty big concern for those of us who are focused on patient access. Of course, that's only just a little bit of the puzzle at this point. We have with Generous and Globe and Trump RX and a bunch of other things that are happening all at once, the possibility that there are interactive effects. Certainly those interactive effects have never been studied. And the significance potentially for innovation could be quite dramatic. The estimates on just the federal use in the Medicare program of this metric, varied pretty significantly. The CBO said, well, over 10 years, we don't think it will affect more than 30 drug launches. University of Chicago said 130. Neither of them looked at the possibility of other governments, state governments, applying that metric. None of them looked at the possibility of these other pricing changes occurring in the same timeline. That's a pretty scary thing to a rare disease patient like me, for whom there is no currently available treatment and who is entirely dependent on the development of new innovative therapies for rare disease patients. So I think that's, sort of the single core biggest problem, but it's not certainly the only problem. We also have very significant issues here in terms of trying to figure out whether there's really any direct benefit to rare disease, other prescription drug patients. The language in that's being employed in Virginia is squishy at best. Happy to talk about how it's squishy. But it is, in fact, not particularly clear that whatever benefits are realized would actually be benefits that the prescription drug patients themselves, whose products are subject to MFP, would benefit from. That's a difference between the way the state is talking about using the metric and the way the federal government used the metric. The federal government was quite clear that the net price that was being created here would have to be the basis of all out-of-pocket determinations for the patients who are on those drugs. And of course, there's a $2,000 cap now under Medicare Part D. There's no discussion of a cap here. So we have a metric in an apples to oranges environment.
And Bill, I just have one follow-up question before we move to Bridget to talk more about the patient journey. We've had federal price controls for decades, right? And we've had federal drug prices for decades. We've had supply schedule prices, 340B prices. We've had Medicaid best price. And yet we've never done this before. What makes this an attractive, or what makes proponents of this mechanism think that using MFP and expanding as you described, a price that's discreetly tailored for a program viable in a commercial setting?
Well, I imagine that the advocates of this language are framing it as, hey, this is a price that the drug manufacturers have agreed to accept in negotiations with the federal government. The federal government is very smart and has lots of resources, and they have figured out what is, in fact, the appropriate value of this product. But again, even if one accepts all of that, and I have my doubts about those premises, but even if one accepts that, that then goes back to the fact that we're talking about apples to oranges. One of the elements in a manufacturer's decision to quote unquote accept this price, if that's really what can be said is happening at the federal level, is that when this price is implemented within the federal program, they're relieved from certain statutory rebates that they would otherwise have to pay. So there's a give and a take with respect to this price. It's not present in Virginia if Virginia adopts this. And so the calculus about whether a manufacturer or a pharmacy or any of the other stakeholders view this price in a state context the same way they view it in the federal program context is a leap of faith at the very least. And as a rare disease patient, I don't want to leap. I don't want to trust to faith. I want there to be analysis.
Well, thank you. And Bridget, you've been in kind of the center of things in Colorado now for years. And last year, we embarked on a process in Colorado that basically did as Bill just described, used MFP as a surrogate and began to roll that out as a number that would be plugged into a UPL authority. I would love to have you share for our group what the impact has been, how they did that, and what you as a patient now observe in the marketplace because of the use of MFP as a UPL in Colorado?
Absolutely. Our board decided to use MFP for Embryl as their upper payment limit. And I would like to say that there was some science to it. In Colorado, the upper payment limit has to be more than MFP. And so our $600 per 25 milligrams of Embryl was decided because the chair of our board likes even numbers. So there was no scientific basis for it whatsoever. Um, and it hasn't gone into effect yet, but we are seeing changes in embryo utilization. Patients aren't necessarily getting it because they're afraid to start it if their pharmacy cannot stock it, which they have realized that it would be a $68 loss if that $600 per 25 milligram UPL goes into effect. If they can't stock it, we're not going to be able to get it. And with Enbrel and those types of drugs, if you end up starting it and then stopping it, there's a very good chance that it will not work for you again. So this is kind of dangerous territory. And one of the things I'd like to kind of mention here is that, like Bill said, we have maybe a quarter's worth of data, but already Bausch has pulled its entire drug catalog from the 340B rebate program, and in response to the MFPs and CMS price negotiation. Then we have the drug Xifaxan, which is now no longer going to be covered by Medicaid as a result as well. And Novo Nordisk did the same. They stopped their upfront rebates for 340B because now they have to verify whether or not they're getting the CMS negotiated price. And if so, there are no other discounts being offered. So we still have yet to see what the true impact on all of these programs. And as you know, 340B keeps a lot of rural hospitals and federally qualified healthcare centers in operation. So there are a lot of unknowns with this practice.
Wow. I hear the theme coming from all of you about the unknown here. And, as we have been working here in Virginia, of course, we have been told that we can overcome the unknown because, we're Virginia and we can do it better than other states. And yet we're utilizing the same mechanism. And, Derek, as you've looked at this, I think both Bill and Bridget had mentioned that shifts are occurring in the marketplace in terms of, the ability to cover. Bridget is obviously talking about what's occurring before implementation of this MFP-based UPL. Can you talk to us a little bit about some of the concerns with implementation of a UPL? No matter the number that you plug into it, plans have been pretty transparent about what they think they're going to do.
Yeah, Mike, there's concerns up and down the supply chain about this. We'll start with pharmacies because they've issued warnings about, MFP, which is now in effect for Medicare. I think a September survey by the National Community Pharmacists Association showed us that 1 in 5 pharmacists, community pharmacists, local pharmacists, were not planning to stock at least one of the drugs subjected to an MFP due to reimbursement concerns. And still at that point, 2/3 more were considering the same. So in total, if everybody decided not to, that'd be about 90% of local pharmacies that are telling us ahead of time that this is going to be a problem for them. And of course, if pharmacies can't stock a drug, then patients can't get it. Fast forward to the end of February, the community pharmacists rolled out another survey, and it showed something like 78% of pharmacists were having trouble navigating claims and reimbursement through the system that Medicare had put together. Reconciling claims was how they put it. And so I think that just goes to show some of the unknown, the unanswered questions about how this really works and the problems that small pharmacies are facing, which, Bridget talked about, rural communities and health clinics. Those are serviced by small pharmacies, a lot of rural communities. So that's a real problem. Then talk about the next step up. You've got the health plans, right? And Avalier, in conjunction with the Partnership to Fight Chronic Disease, has done 2 surveys of health plans related to upper payment limits. and found that they are consistently telling us that when UPLs are instituted, the trade-off is going to be increased costs and decreased access for patients. I don't have the stats in front of me, but what they've said is that you could expect premiums to increase. You could expect co-pays or co-insurance to increase, and you could expect access to change for either the drug on subjected to the upper payment limit or other drugs in its class as they consider, their formulary constructions. And so, of course, all of those things are a problem for patients, and they run, they're counterintuitive to the goal of the legislation in the first place. And then doctors, we did a survey of clinicians last year, specialists, and found that when it comes to upper payment limits, we surveyed them in the states with boards that are considering them. Something like 96% of specialists were concerned about non-medical switching for their patients as a result of upper payment limits. And literally 100, every single respondent was concerned about the impact of upper payment limits on their practice as it relates to administrative burden and time spent not helping the patients. And so, when it comes to the unknown, you're right. We haven't seen it in practice. As Bill said, MFP's only been here for 3 months, but there's sure a lot of evidence heading into them that should concern us when it comes to patient care.
Bill, I was actually reading through the Vermont legislative report for 2025. And there was a recommendation by the team in Vermont with all the changes in the marketplace, whether it was MFP in the IRA, Trump RX, all of these things that are kind of going on at once, MFN, Globe and Guard, all the, reference pricing. Their recommendation in Vermont was to pause and not implement a UPL, whether it was based on an MFP or a number that the state came up with. Bill, you had mentioned, the impact to the pipeline of rare meds, which we saw that CBO saw that under the IRA, other groups have modeled, et cetera. As you look at kind of that whole kind of what's going on right now, how can you break out something like an upper payment limit and really look at the impact here in isolation, or to give advice to a state like Virginia moving down this pathway? But how could they really understand the impact of this? And what is some of your guidance given this new mechanism?
Yeah, well, I mean, this is the kind of research that I do with the very smart people at IQVIA. The potential answer to that is a differences in differences analysis. That, however, isn't really an option when everything is different at the same time. And that's sort of the circumstance that we now find ourselves in. It's very hard to isolate the impact of any particular change because everything is changing at the same moment. So that is, I think, a huge source of concern. Whether you're an advocate of this policy or you're not an advocate of this policy, I think if you're reasonably objective, you have to understand that acting at this point in time is very difficult to justify and to be able to test in any sort of rigorous way.
Wow, that's a really important thought, Bill, particularly in Virginia, as the governor is reviewing the bill, and potentially there may be opportunities to send the bill or portions of the bill to study committee. Yeah, just the muddy water that they would even have to study to understand the impact of this new Virginia bill.
Yes, indeed.
So, Bridget, it's interesting as we talk about not only this confusion, as Bill talked about, in terms of interpretation of what's going on and how to really understand the impact, is it's even more confusing for patients. We've been told that MFP is just using a federal number, and that we're just expanding the savings. And yet there's confusion because others will tell us it's not even a price control. And could you talk to us a little bit about how to navigate that? And as a patient advocate, and I know you've been involved with other state PDABs as well, where these things are being kind of framed that way. How do you navigate that? And what would be some of your key messages for really articulating some of the things that Bill and Derek talked about, which is the uncertainty that patients need to bring to the table and need to be able to articulate?
I think right now it's very difficult because the upper payment limit here in Colorado doesn't go into effect until 2027. And so we are sending out letters and messages to different rheumatological organizations, letting them know, hey, this is coming, be prepared. And we're trying to reach as many patients as possible because the problem ends up being if you need a specific medication, let's say, for my disease, there is one medication that I can take and I cannot take anything else. Um, how are you going to navigate that if the insurance changes its entire formulary and now your medication isn't covered? The Division of Insurance has said that they're going to have some sort of exceptions process, but that just adds another layer, another barrier to entry for the patients here in Colorado. And so what they really need to understand is this upper payment limit, it does not impact out of pocket costs. For an adult dose of Enbrel, you're still looking at $4,800 a month. And there's no way to afford that. We also don't know what the impacts on patient assistance programs are going to be because, regardless of the $600 per 25 milligram UPL, I still have to use a patient assistance program to be able to afford this medication and the copay. My insurance is not designed to where the copays are affordable, and they're starting to use co-insurance. We're starting to see more AFPs show up. And so we're trying to reach as many patients as possible to let them know these are the changes that are happening. This is the process that the Division of Insurance says that you're going to be able to go through and, negate this UPL, but we haven't seen it in practice. And so we're trying to prepare patients for that discontinuation of care. For example, if they use Trikafta and they had put a UPL on Trikafta, if you miss one day of that, you could end up in a really bad situation and then you could end up dying. This is not a medication you can skip. You don't have months to wait while the Division of Insurance works with the carrier, who works with the manufacturer, who, going through all these things. Unfortunately, I feel like they think we have all this time in the world to go navigate insurance, navigate copays, and navigate assistance programs. But right now, I'm just trying to reach as many patients as I can to say, hey, this is happening to Enbrel. You need to watch your coverage. And if something happens, we need to get this, in front of the DOI, in front of the legislators as soon as possible. Because honestly, no one knows this is happening. This has been sold to people as directly saving money to patients and Colorado consumers. And the statute in Colorado does have a nice little clause that says, they have to show carriers and whatnot have to show how they're using the savings for Coloradans. But all that does is just leave us in a position where the insurance companies are going to say, well, we could have raised your premium $50, but we only raised it 48. And that helps nobody.
Wow, that's really an important thing to understand. Excuse me. To Bill.
I'll just quickly note that that's the exact same problem in this language, right? It says that the insurers are supposed to show how any benefit, which of course raises the possibility that it is recognized that there may not be benefit, but how any benefit is being used for consumers. It doesn't have to be that the benefit goes to patients on these particular MFP drugs. There is some language about prioritizing prescription drug consumers, but not specifically the ones on these drugs. And the overall overarching problem is what was just observed, that because money is fungible, the insurer could simply say, well, we would have increased the premium by an additional 5%.
Yeah.
We didn't do that. And so there is, in fact, no net improvement to affordability. Perhaps even there is a net loss of additional affordability in the guise of having done something positive.
Well, and just to add on to that, I mean, what's wild, to Bridget's point about how they're selling these policies, and Bill's point about the language and how it benefits patients, is the fact that they're now referencing the Medicare maximum fair price. And we've seen this play out for Medicare patients already on the drugs that are subjected to it. You know, in 2025, the Pioneer Institute did a study showing that out-of-pocket costs on the drugs subjected to the MFP before they took effect, but as plans prepared for that, the average out-of-pocket cost for the patient went up, not down, and it went up 32%. And you know, a study that was sort of complementary that came out of USC showed that plans were also, increasing premiums, but more importantly, there was a marked shift from copays to coinsurance. And Avalier did a study at the end of the year, early this year, showing that trend is only continuing. And so, the question is, are patients seeing benefit from it? To your point, Bill, we're 3 months in now. We'll find out, I guess. But leading up to it, there was concern that they certainly wouldn't.
I would like to have all of you kind of offer some views on this next question that I have. And then I'm going to shift to the Q&A or questions coming from our participants as well. When a lot of this bill was rewritten in Virginia, we were told not to worry about it because first they had exempted rare disease therapies. And then, with this rewrite that was basically dropped just before the vote, of course, they took out a lot of the protections and basically just said, oh, we're using MFP and you're exempted from that anyways. As we know, only 5% of rare diseases, conditions, et cetera, have a therapy. And Bill, you articulated that really well. Many of our rare community don't even have an approved therapy or a therapy with anything in the label or even in the compendium. And so 95% of our patients are going to face, situations that Bridget talked about where they may be successfully on a therapy and face switching. Could each of you talk a little bit about, the implications to the rare community, and not from on-label indications, but talk a little bit more about, your experiences, maybe some of the programmatic impact, Derek, and Bill, some of the real concerns about limiting access in the rare space.
Well, I'll just say, I mean, your point's right, Mike. I think the way that these things are structured presents a fundamental misunderstanding of a rare disease patient, right? The idea that the only medicine that one might be on is a drug specifically for their condition, I think just isn't how patients really live, or the reality of rare disease. And so, the fact is that all of these other drugs that they're selecting could easily impact anybody with a rare disease or anybody else too. And that's a little bit of a scary prospect when we talk again about all of the challenges we're seeing up and down the supply chain, or concerns about access. So that would be our number one concern in that space for sure.
Bill?
Absolutely. As a patient, the drug that I am on is not indicated for my rare disease, but it does help. And so if anything happens to that one drug, I don't have a therapeutic alternative, and my body will start eating itself again. And it's a very scary thing to have to sit there as a patient. If you're using a drug for an off-label, thing, you already have barriers to access. The insurance is already questioning you constantly, and you have to constantly justify why you need this medication. And this is going to add a whole new layer of having to navigate the system and making sure that we can get our medication and have that continuity of care. You know, if my drug gets a UPL because it treats common conditions that are not my rare disease, then not only am I having to navigate the insurance, but now I have to figure out this division of insurance process, you know, and how long is that going to take? How many surgeries am I going to need as a result because of so much damage? You know, right now, I'm not using any type of benefits or state assistance or anything like that. And I'm still able to work. I'm still able to play with my grandkids and participate in life. And if I lose access to that medication, all of that goes away. And so there is so much here, especially for a rare disease patient, to think about as you move forward through these policies that are well intended, but they're only considering the manufacturer price. They don't consider the entire supply chain, you know, how PBMs and reimbursements go and what the pharmacies are dealing with. So there's a lot to unpack here.
They also don't consider, you know, our coalition is called the value of care, right? And our belief is that value should be considered through the eyes of the patient who receives the benefit from innovative medication and the prescriber who values that drug as a tool in their toolbox because they treat individual patients. They don't look at it as a um, one size fits all issue the way that a prescription drug affordability board does when it sets these prices. And so, you know, I think, you know, you touched on it, Bridget. I mean, there's also a fundamental misunderstanding of value and what it means to real people, individual patients too.
Well, I can't add anything to that because those two answers were so great. But I did want to say, Mike, two things from a legal perspective that I think are interesting about the Virginia language. The first is that in talking about data and transparency from PBMs, there are references to a bunch of items, including pass-through of rebates, that sound like they could produce some good transparency. And that as I read the language, I was, well, look, there seems to be at least some upside here. That's great. Unfortunately, when I looked closer at the language, it seems to limit the items that have to be reported to those items which are paid or payable by the pharmacy benefit manager to a pharmacy. So that's actually a very limited cut on transparency and really one directional and not really not really of the comprehensive nature that's necessary to get any sort of meaningful transparency about how a PBM functions as a middleman and how it may be actually increasing costs, not decreasing them. The other thing I just wanted to mention really quickly, because I found it fascinating, is the whole notion that a drug manufacturer, I think the answer they give to these concerns about access, the advocates of this language is, well, look at the bottom of the language. The language says that a manufacturer cannot withdraw a product except on 180 days notice, and that if it withdraws the product from the state, then it'll be subject to a fine. Well, there's this thing called the Dormant Commerce Clause, which is meant to protect Congress's authority to pass legislation that regulates interstate commerce. There's a pretty substantial issue that those quote unquote protections against withdrawal are actually unconstitutional. I don't see any real discussion of that legal issue in the framing of this language and the debate around this language. That's certainly a source of concern for me.
Wow. And that you're right, Bill. I really haven't heard that as part of the debate yet, although I do believe that, you know, council and the governor's office is looking at those sorts of issues as they evaluate the legislation. You know, there were some pretty significant concerns about, you know, can we actually implement something like this? And so it'll be interesting to see what their response comes back to us on that, and if they are, you know, concerned, and ultimately if we can get this to go to a study committee. I think that would probably be the best outcome, and then we can look at the study committee, and hopefully they will explore those exact issues. I have a couple of questions from our participants, and I would just, before I get into them, encourage you, if you have some questions for our panel, please feel free to shoot them through the chat. We will be going through those questions, and then we'll shift gears a little bit to Illinois and Louisiana. The first question is really specific to Colorado, but I think focused on exactly what we're talking about. Is there any data yet that we could share out of Colorado that shows the decreased use of Enbrel after the MFP was announced? Notice, not implemented, but announced. Bridget?
Right now, I don't know that there is. We're still trying to gather that information. A lot of patients and providers are just not aware that this is even taking place. So they may not even know that maybe that insurance denial or that formulary change that happened in January was a result of this. So, we're still trying to get all of that information to be able to present it. But we are hearing stories of formulary changes, increased pre-authorization requests and step therapy, which is a big thing in my disease category.
Yeah, in fact, anecdotally, we heard a lot about step therapy recently in Colorado, and basically step therapying the patient to death. Bridget, as you said, there are a number of biosimilars in the marketplace for some of these therapies, and they may not always work. And so having to step through them means that by the time you get back on the original product that you were doing well under, you may not. And so that's a real concern, and something I don't think that is considered very, very well by the proponents of the bill.
Yeah, I would have to agree. Colorado has all payer claims database and an organization called Civic, and they came out with a report at the beginning of last year that said of the top 15 most utilized drugs, 9 actually had biosimilars. And so it looked like rebates were actually driving utilization, not necessarily cost. So there are a lot of factors in here to look at and try to compile together to get a better picture of what's happening.
It is interesting the PDAB's own data doesn't support the PDAB's own decision making at times. So let's move on. There's an interesting question here, and I will direct it to all of you because this is kind of touches on something that we've been talking about this morning. Let's see. This is from Colorado, and at a hearing last week, the opposition to the rare disease exemption language that has been introduced in Colorado stated that the UPL was written to pass the savings on to patients, which, Bill, you just talked about. We have told the legislature that this is not actually correct. What would be the best way to convey this to a legislator who knows little about the policy?
Honestly, I would just send that 2-sentence clause over to them and say, this does not say that it has to be passed on directly to me. All this does is give them the opportunity to say, we could have, charged you $50 more, but instead it's 48. Because if you think about it, you've got an upper payment limit on one drug, and everything else like hospitalization costs, medical supplies, things like that, all of those prices are still going up. And so it's not going to manifest into actual savings for the patient or any of the Coloradans that are paying premiums as well. So I think it's important that they understand the statute, how vague it is, and how easy it is for carriers to kind of work around that language.
Yeah,
I,
I think one great thing to do is to give them the Colorado Insurance Association statement, which says, look, we are not promising, we are not committing that this is actually going to have any beneficial effect from a patient affordability perspective.
Yeah, I think, we always talk about UPLs as taking a very narrow perspective of a really complex problem and complex supply chain. And that is kind of evident based on the supply chain dynamics and through, the pharmacies, the doctors, everybody that we talked about before. But the challenge is that, who's at the end of that chain is the patient. So by the time this all gets sorted out, how can we guarantee that the patient is going to see benefit? And again, in Medicare, we're kind of seeing the opposite so far.
I think that's really important. And if you look back at the data, Derek, that you were referencing on this
Mhm.
of the plans and PBMs, et cetera, they actually point to that to say that the patient is the most going to be impacted by these UPL policies, the
Yep.
plans, because
Yeah.
they're looking back at the options and they're saying none of these are good for the patients.
Right. Patients, again, being the one who needs the medicine, they don't have options to work around these policies, right? An insurance company or a pharmacy benefit manager can, manipulate their formularies however they see fit to make sure they come out okay. And a pharmacy, whether they want to or not, can still choose not to stock it if it's going to hurt them and their business. But at the end of the day, Bridget needs the medicine that works for her. There aren't a lot of choices. And so the patient's the one who is certainly going to be the most impacted, whether it's for the better or not.
So we are actually running out of time very quickly. And I think in part because this is such a interesting discussion that we're having, so the time's kind of flying by. And so I want to share this question very quickly, which is the practical question. How can I share this information and engage with people in these states, whether it's Virginia, Illinois, or Louisiana, so that they can make a change to their views on PDAB? Of course, in Virginia, that may be a challenge, but as we talked about at the beginning, the doors are still open at the governor's office. So what would be your recommendations to get people to actually weigh in and say, you know what, I'm comfortable enough with the information, I'm going to speak up?
It's a good question. There's a lot of opportunity just because there's so much action on this topic, whether you're looking at legislation or existing boards that are doing their work. Colorado just held its first meeting in 3 months. Maryland is fast and furiously working its way towards UPLs on 4 drugs, and offering documents for public comment almost nonstop. Virginia, like you mentioned, the governor's office, that door is still open. Go through it. Tell them what you think and raise the concerns while we still have time. Active legislation in Illinois would create a prescription drug affordability board and in tie it to MFP in some ways. And Louisiana's got 2 bills that it's looking at right now and moving. One would create a prescription drug affordability board, and one would implement Medicare reference pricing. So those are, a few places where people could speak up right now if they'd like to. And if anyone has questions, I'm sure they could reach out to me or to your group, Mike, or anyone on the call to find out more about those states and how the legislation is moving.
And I would just add to what you're saying, Derek, is that we have a lot of the information both from our group as well as other groups linked on our website. So you can find the information there. You can find our policy alerts. You can find our papers. You can find the papers that were done that Derek referenced earlier on PDAB or PBMs and the challenges of payment that are going to be kind of thrown up to patients on our website. You can find statements, letters, testimony, etc. So there is good information that you can take back to your state. But at the end of the day, you can contact us. You can contact Derek's organization. You can contact Bridget's organization, and we can help you. Whether it's just trying to frame your own experience or helping you navigate some of the information that we have on our website or that we've utilized. We are here to help you and help your voice be heard. So please don't hesitate to reach out. And I think that's a really important message to send to a lot of patients out there trying to figure out how to get more involved on PDAB. Bill, did you have any thoughts as well?
Well, I would say to a patient who's trying to figure out what to say in a short letter, that the most important thing is to talk about their own dependence on the therapy that they care about. To say that you're aware of the consideration of this prescription drug affordability board, that although obviously affordability is a really important issue, I'm worried that the proposal being discussed now is untested and risks unintended consequences. And if you just say those three things, this is the therapy I care about. Yes, affordability is an important issue, but I'm worried that what we're looking at here is untested and may lead to unintended consequences. I think you've written a terrific letter.
Yeah. And it doesn't have to be an opus. It doesn't have to be very long. Bridget, any additional thoughts?
Absolutely. I would definitely share your story. There are legislators. You can actually get involved once these boards are created. You can get involved. They usually have public testimony. Every single legislator has my x-rays from when I lost access to therapy a couple years ago, and I ended up needing 10 surgeries as a result of that. And I am not going to have 10 surgeries because that's just overwhelming. But now I am disabled at a level I never was before. So it's important that these legislators understand and see that there are humans and there are very real potential consequences if we don't have access to the care that we have now.
And if any of you have questions about framing that letter, Bridget is also a resource who works directly with patients every single day. And please reach out to Bridget because she brings that no nonsense kind of attitude to communicating with policymakers to help them understand. So, Derek, any final thoughts?
Oh, just everybody, thanks for being here. This is a policy challenge that's not going away, where boards are stood up. They're actively working month by month, and it takes a lot of work to push back on them with any success. We've seen it happen, but it takes the work. And this year we've seen legislation like this in in a serious fashion in 5 or 6 states. Next year we'll probably see more again. And so hopefully as more time passes and evidence mounts that these are bad policies, we can stop them from spreading. But I guess the message is just thanks for paying attention now, and please be vigilant with us in the future.
And I would just add before we close to Derek's final thought there, we have an opportunity in Virginia to make a difference. The door is still open to us to communicate with the governor. Let her know your concerns, as Bill said, simply, directly, and with your patient journey at the forefront. We have an opportunity to make a difference because all these other states are watching Virginia right now. And if this MFP UPL passes unscathed in Virginia, you are going to see additional momentum, as Derek just described, in these other states. And we can throw in Rhode Island, we can throw in, California, we can throw in some other states that are already considering these things. So taking a stand in Virginia is very critical in these final days to make sure, even if it's a simple note saying, I am a patient, this is my therapy, this is why this matters to me, don't take this decision from my physician's hands. That's simple. And keep that door open so that we can do the very best we can in Virginia, because these other states are watching and they're going to take their cues from Virginia on MFP and on the use of a UPL. So with that, I would like to thank our panelists, and I would like to thank all of you for attending and joining us today. This has been a really terrific discussion, and I just want my panelists to know how much I appreciate both their professional and their personal association with us. And we appreciate all that you're doing for patients, and thank you for joining us today. And again, thank you to all of you for tuning in. This is an important discussion, and we look forward to being engaged with you. Thank you.
Thanks, Mike.
Thank you.